huge thank you to Jill and everyone there for inviting me. I wish I could be present. I haven't been out there in a while, so I'd love to come out and do this in person again in the near future, hopefully next year or the year after. But what I would like to talk about today is just hopefully whet people's appetite a little bit for some of the advances in assessment and intervention that I think are necessary and hopefully to some extent, at least in progress, for individuals with autism and severe intellectual disability. So I'm really focusing on that subpopulation of the autism spectrum. And I'm going to be providing a perspective as somebody who is a provider, but also a parent and a researcher. So I want it to be taken in that context. These are my disclosures. They're not terribly relevant to this talk today, but I do want to mention them and at least show them. I am funded to do some work around assessment to improve assessment for individuals with autism, and so it's important for me to disclose that. Really quickly, I'm going to go very fast today. Like I said, the goal here is not to be comprehensive. It is just to give you a flavor. I'm going to start off by talking about why and how we can improve assessment for individuals with autism and severe intellectual disability, including touching on some new measures that we've created, how to improve the intervention process. And I'm just going to talk about 4 practical things that we can do. And none of this is going to be groundbreaking or earth-shattering for this audience, but there are more things to keep in mind. And then I'll end up on additional needs for individuals and families with severe ID, including how we can create better supports, better training, and better systems of care, especially around emergent and chronic challenging behavior. So why should we improve assessment? Well, assessment is absolutely crucial for having an evaluation and really a continuous evaluation of needs for the individuals. If we don't know the person's strengths and weaknesses, we can't design the best intervention strategies and really just the best strategy for their whole life. I mean, this is a very simple example, but a 15-year-old with ASD and ID who is reasonably fluent in terms of their speech, and that could be with or without a speech generating device, that has no significant challenging behavior and has a relative strength in receptive language skills is going to have very different needs than a 15-year-old with ASD and ID who is non-speaking with very limited speech generating device use, has aggression and self-injury, and a relative strength in spatial navigation skills. Those are 2 very different profiles with very different needs and very different intervention planning strategies. And I haven't even touched yet on the individual and on the family and the external environment, which of course are also going to then play into the intervention strategy. So how do we improve assessment? Well, we have to start using measures that are more appropriate for this population. You know, we've had some great measures in autism and in developmental disability over time, but we're now seeing sort of the next generation of measures being created. I'm not going to get into the details here, but you know, the social responsiveness scale was a very useful measure of social behavior for many, many years and still has a place, but we now have newer measures that were designed specifically for this population so that parents aren't frustrated with completing them or caregivers aren't frustrated with completing them, and that they're more applicable to individuals with autism and intellectual disability. Same thing with like the PEDS-QL, which was developed for a general pediatric population. We now have quality of life measures that are more appropriate for individuals, whether they be children, adolescents, or even adults, where we can investigate psychosocial quality of life aspects, child, family, caregiver, external support, financial, et cetera, aspects of quality of life that are much more appropriately framed for this population. And, you know, we have to evaluate for strengths. And I think a lot of times we focus on evaluating for weaknesses, and I understand that there's a value in that, but we have to focus on strengths as well to develop the best possible intervention plan. So I've listed 4 here, you can read them, but I think you can see, you know, whatever, you know, I'll just touch on the last one. If somebody has physical capacity strengths and energy strengths, those actually could translate to employment opportunities and different skills that we might want to teach that individual. So there are all kinds of ways that strengths can play into the planning process. And then we should always focus, especially as providers, on eliciting both typical and best performances. If you don't elicit a best performance when you're doing an assessment, it's really hard to know what might be possible. And we know that many of our loved ones with autism and intellectual disability are very variable from day to day in terms of their ability to elicit their best behaviors. And so we want to try our best to do that. You know, a lot of this has been informed my own experience with my son, Sean. And one of the things that really motivated me in this process was to try to develop measures that don't assume speech or don't assume particular motor skills or functions, or don't assume a high level of ability or capacity. And so we started working with patients and families and also clinician experts in this area to develop measures that would be better for this population. So not just parent questionnaires, which of course we have worked on, but also to collect information directly from the individual. We've started to create these webcam measures where we have the person sit in front of the screen, even if they can only sit for a short time, and we can collect some information about them just from being able to sit in front of the screen for a very short period of time. And we have people that do this with tablets, laptops, PCs, et cetera, and we're trying to make it as friendly as possible. So even if there's significant movement, we can still capture good data. And we've been focusing on including items that differentiate at lower levels of capacity. And the reason for that is so that progress can be tracked. If we don't have items at lower levels of capacity, then we don't know when our interventions are working well for these individuals. And I mentioned some of these objective measures that we're creating. We're using webcam eye tracking, and so that we can do this at home. We're using things like automated behavior coding, again, so that we can capture data even from very significantly impacted individuals. And even things that you would be surprised that we can do in individuals with severe ID, like pupillometry. But we can do this now because webcams can measure the pupil and they can measure rapid changes in the pupil. So if the person can only pay attention for 20 or 30 seconds, that's okay. And it doesn't even have to be the same 20 or 30 seconds all the time. Sometimes we can chop it up and still get good data. But the key here is we don't require motor or speech responses. And that's going to allow us to do a lot more from an assessment perspective with these folks. These are 4 paradigms we've created to try to collect via webcam. And it's really just about saying, you know, look wherever you want for the social stimuli, because we just want to see, are these individuals picking up the social information? For the receptive language, it's like, hey, look at the ring, look at the ball, look at the person eating. We just want to capture their ability to follow language. For processing speed, it's like, look at all the stars as quickly as you can. And we developed a single word reading paradigm just because the Simons Foundation, who was funding us, wanted us to say, hey, for some of these non-speaking or nonverbal individuals, can some of them read? And so we have a single word reading paradigm where we present fairly simple words, and we just want to see common words that they'd encounter in everyday life and see if folks are reading these. So I'm going to shift out of assessment now into intervention and just quickly mention that, you know, we really can do some very simple things to make these individuals' lives better and the lives of their families and loved ones better. One of the things we can do is tailor intervention as early as possible. So I'm going to show you a graph here. And this is a graph from an early intervention program that I used to oversee at the Cleveland Clinic. And what it shows here are changes over time once people enter early intervention from 0 to 36 months in their language. And you can see that there's really nice increases. And by the way, those decreases at the end are kind of artificial because a lot of people are leaving the program that are already made tremendous progress. So we're really seeing really huge increases and huge improvements in language over time in these individuals receiving early intensive behavioral intervention. But the problem with this graph is that it misses what's happening in the group of individuals with autism and severe intellectual disability. And so what we did was we started to break this apart, and we actually did this empirically so that the data told us who is this group at the bottom of the screen that I've outlined in the red box here. And this is a group that is showing lower levels of language at the beginning of intervention. And that language level shows a slight decrease over time. It's pretty slight, so I think we can call this fairly stable. But what this tells us is that we need to tailor early intensive behavioral intervention for these individuals so that they can keep pace in language development. The fact that that line is fairly flat tells us that with an intensive intervention, we can help these children to keep pace, that they can actually maintain a relative standing compared to their age and peers. So we need these individuals to get a higher intensity and a better tailoring of their early intervention. They're going to benefit more from a greater focus on procedural learning versus, say, semantic or declarative learning. What I mean by procedural learning is learning by doing versus learning concepts or learning facts or ideas, right? And so learning by doing, I'll give you an example. My son learned his single-digit integers, numbers, through using a microwave, not through actually being taught 1, 2, 3, 4, 5, 6, right? A lot of these individuals are going to require more visual supports, and many of them are going to have longer processing time. So the way we provide directives and instructions has to be simpler, slower, better for many, better quality for many of these individuals. We also want to continually screen for and anticipate challenging behavior so that we can cut it off at the pass. My son has a very nice temperament in general. So for many years, I thought, well, I don't need to worry about challenging behavior with him. And then he became an adolescent and we had all kinds of self-injury and a little bit of aggression. So we need to be able to cut this off, get differential reinforcement plans in place as soon as possible. Even later in adolescence, I've seen this emerge, and early adulthood, I've seen it emerge as well. We've developed a new scale that's intended to be a screener for challenging behavior. And we're trying to get different places to adopt this screener so that we're not missing kids who are starting to develop emergent challenging behavior and need the right kinds of intervention. This table, I think, is very sobering because what it shows us is that individuals with autism, with either profound autism, which is a new definition, or autism, severe autism, symptom severity, or impaired cognitive level, regardless of how you define it, a huge proportion of these individuals have some form of challenging behavior, and half to 3/4 actually show 2 or more types of challenging behavior, whether that's property destruction, aggression, elopement, whatever. And so this means we have to pay very careful attention and continuously screen for challenging behavior in these individuals. So the other 2 points I'll make about improving intervention are focusing on communication and other functional behaviors. We have data to show that if you focus on communication early, you can head a lot of the challenging behavior that we see off at the pass, and you can build these functional replacement behaviors that help people to feel more successful and to be more successful in their daily life. And then not forgetting about the relationship. As parents, we all know this, but I think as providers, sometimes we forget that these individuals, especially the non-speaking, non-verbal individuals, the relationship's actually even more important for these people. We sometimes, think, well, we just need to be good to them. Well, yes, we need to be good to them, but we also need to focus on what they like, what they would like to see in the relationship, how they would like to interact. And really focusing on understanding them and what their, not just their wants and needs, but how they like to interact socially. And then I'll just sort of end up by talking about additional needs for families and individuals with severe intellectual disability and autism. We obviously need better supports for these families. Respite care can be improved. Community participation options that actually make sense for these individuals. Sibling supports, because like my daughter really has struggled over the years with her older brother and how to be a good younger sister to him. State and county services that actually help. I'm not going to go through all these examples. You can read them, but we don't have, at least in Ohio, and I'm sure California is probably a little better, but at least in Ohio, we don't have the right services in place for these individuals yet. I think we're doing better for the more mild, moderate, or cognitively able individuals, but we don't have the right services in place yet for severe autism, intellectual disability in many different ways. Our support administrators need better training. They need to help families in a different way than they are. And we really need extra funds to be put towards these situations so that these families can get the right services in place, make sure that they're providing therapeutic supports that oftentimes are very hard to find. I mean, in our family, we've had great trouble finding therapeutic supports for my son because he's more severely affected, because he has a lot more intense needs. It's time for us to start thinking about better training for providers, whether that be in speech language pathology, psychology, psychiatry, BCBAs, intervention specialists. We need tracks and certifications. For supported living providers, which my brother happens to be a supported living provider, I think we need much better training and certifications. And what kinds of additional funding makes sense for this population? Our experience in Ohio, my wife and I have been fighting in various ways in Ohio to get better payment for Medicaid providers, making sure that there's actually coverage for ABA services after age 14. Our new program, Ohio Rise, initially wasn't really even designed for people with autism. So how can we include people with autism that need those services in that program? Just all kinds of things that we can do. And I know Ohio is a unique state, but I imagine that this is a problem around the country, at least maybe in different specific ways, but in general, a problem even in California. And then better systems of care for emergent and chronic challenging behavior. Our psychiatric inpatient programs are just not well designed for this population. Emergent challenging behavior is not appropriately screened for and handled. We don't have medium-term care facilities for individuals so that we can get the behavior to a better place, so that then the child can go back home and be integrated in the home with parent training, with social work support, et cetera, to be able to help these folks. So this is something we all need, I think, to push on if we care about this population. I'll just end by thanking everyone who's been helping us in the assessment process, building better tools, building better measures for this population. And then, of course, I want to thank my longtime friend and collaborator, Antonio Harden, who's very well known to many people in the audience there. And then also my collaborator, Mirko Ojerovic, who's just recently moved from Melbourne to Stanford. So I'm sure many of you, if you don't already know Mirko, will get to know him. Thanks a lot for the time, and I'd be happy to take questions if there is time.
Hey, thank you. Thank you, Tom. We're having a little bit of audio trouble. I'm going to ask you to first take questions that you see on Zoom. Do you see them in the Q&A?
Yes, I do see some questions, actually.
Okay. We have 5 minutes, and so choose, 2 or 3.
Okay, great. First one, are there treatments for young adults to gain planning executive functioning skills? Yes, there are. A lot of behavior therapists are BCBAs. My wife is a BCBA, are learning a lot more about how to apply behavioral intervention strategies to help individuals gain executive functioning skills. So things like planning and organizing, sequencing information, emotion regulation is part of a sort of self-regulation or executive functioning skills. So there are a lot of different behavioral intervention strategies that you can apply to help with executive functioning. I will also add that some of this is about intervention to improve executive functioning, but some of it is about accommodation as well. So it's a mixture of accommodation and intervention. But yeah, we have a lot of experience now in behaviorism of trying to use prompting and reinforcement to help individuals learn to exhibit these skills more frequently. But it does depend on the specific skill. So going back to earlier in my talk about assessment, we first have to know what the executive functioning profile looks like. Is this person having problems with emotion regulation, or is it more sequencing? Is it response inhibition, like being able to inhibit responses that they shouldn't exhibit? Or is it more about risk-taking and risk avoidance, right? There are many different executive functions, and so we need to know the profile and then develop the behavioral intervention plan for that profile. Second question here, would you please mention some evidence that people with profound autism would develop greatly improved languages if they had optimized early intervention? The study cited showed their language going down over time with intervention. Well, it's going down relative to peers, but it's going up in terms of actually their language improving. So remember, the y-axis on that figure that I showed you is a standard score. That standard score is adjusted for age. And so it's going down slightly relative to their peer group, but their language is actually improving. So if you look at the raw scores, their language is getting better. If you look at the standard scores, it's relatively stable with a slight decline. And in fact, if I had shown you other graphs around receptive language, the receptive language is actually going up in standard score. So not only is their receptive language getting better, but they're actually gaining ground relative to their peers. So early intensive behavioral intervention, if it's tailored appropriately and if it's intense enough, actually does improve language and improves receptive language a little bit more than expressive language. But even in expressive language, you see that these individuals, for the most part, are able to keep pace with their peers and show improvements in their language. So what is the difference between profound autism and severe autism? Well, we're kind of still debating that. Jill could talk about that better than I can, but there's a new definition around profound autism that has to do with some of the functional difficulties and cognitive difficulties. I'm not going to get into that too much, but I think the idea is that if we could start to define a subgroup of autism that has higher needs, that we could do a better job of making sure they're getting the right services.